Thanks, Dr. Hill, and I'd like to thank all of the speakers for really an excellent session. We're going to move now to the questions and answers, and if you have a question about any of the three presentations, please type that question into the questions box on the website, and we will attempt to respond. So we do have already one question, and I think I will pitch this question to Andrea Calcagno. The question comes from Marcello Lins, and it says, is there a possibility of self-administration of long-acting cabotegravir and rilpivirine? Andrea, what do you think? Could patients ever self-inject cabotegravir and rilpivirine?
I think it's a very good question. So the way of self-administration will be a future objective of these kind of long-acting treatments. I think at this stage, doing an intramuscular injection by yourself is a bit difficult. I tried it by myself once I had kidney stones. So I tried to do intramuscular. It was painful. So I think with this formulation, won't be possible. But
thank you. If I ever develop kidney stones, I'm not coming to see you.
But, you're not able to relax when you inject yourself.
So I have a question, Andy Hill, for you. You talked a lot about safety of long-acting formulations in women of childbearing potential, and what would you recommend? What do you think we should do for a woman receiving long-acting cabotegravir and rilpivirine who becomes pregnant? What should we do? And maybe Kim Scarsi and Andrea, I'll also let you respond to that. We know this is going to happen, but you know, in the absence of a lot of the safety data in pregnant women and neonates or in developing fetuses, what would you do?
Yes, so normally in clinical trials, when somebody's taking an investigational drug and they get pregnant, they're normally taken off the trial. Now, I think we have to think about the future, and that there will be women who get pregnant and have babies taking these drugs. And I think we need a registry. We need to be following up everyone for the moment who gets pregnant and look at the outcomes both for the mother and the infant, and actually take control of it. Because if you look at the current system with the antiretroviral pregnancy registry, it just takes such a long time to build up the data to have a large enough safety database to get the drug approved by the main regulators. So I think the way to accelerate it is to have this registry set up prospectively and follow up every woman and see what happens.
So you would not discontinue the injections and switch that woman over to oral therapy?
Well, I think even if they were switched over, it would take quite a long time for the drug to leave the body. So no, I think if we're planning on this drug to be used wide scale, I think we have to be ready for it to be used by women of childbearing potential. I think otherwise it wouldn't be a very applicable treatment for mass treatment programs.
Kim and Andrea, do you agree with that? Do you share Dr. Hill's view? Kim Scarsi?
Well, I'll go first. I think this does offer an interesting opportunity, because we do know that cabotegravir and rilpivirine, even if we discontinue it at the time that we find out about the pregnancy, is still going to be present probably for most of the pregnancy. So I feel like in our normal response of discontinuing an unknown drug to introduce something new as a means to protect the baby, I feel like that ship will have already sailed, because they're going to be exposed to the drug regardless. So I feel like it is an opportunity where we could, as Andrew mentioned, kind of proactively manage this, allow us to do some PK assessments, because that's going to be our other question, is will the physiologic state of pregnancy change exposure and put the mom at risk for virologic failure? But I'd be curious to hear Andrea's perspective as well.
So I definitely agree. I think we probably need to discuss this with women or childbearing potential when they start this kind of treatment, and present them the opportunity, and also said that we don't know what would happen in that particular moment of their lives. But I agree that probably discontinue won't be really useful in the setting of safety of the newborn.
Terrific. While we're waiting for other questions, okay, so there's another question from the audience, and I think this could either go to Andrea or Kim. The question is from Eddie Nakarapa, hope I pronounced that right. Have you thought to boost a dosage of cabotegravir on those who are taking cabotegravir plus rifampicin? So Kim, you showed us data on the likelihood of an interaction between rifampicin and cabotegravir. Could you overcome that interaction by giving a boosting dose, or let's say doubling the dose of cabotegravir? What do you think?
I think it's a great question, and I think it's something that we need additional data to understand. So I'll give my experience in pregnant or in contraception. So we know that there's an interaction with efavirenz and the contraceptive implants that reduce exposure by about, depending on the product, 50 to 80%. So we did undertake a study to increase the dose of the implant by placing 2 implant systems with both types of products. And I would say it responded differently than what we would typically see with an oral product, where if you double the dose, you double the exposure. We did see an increase in exposure, but it did not return to normal. And I think that perhaps goes back to the differences in pharmacokinetics between oral and implantable. So I think with long acting, it's a potential to give maybe a booster dose at that time, but I think that's something we're going to need modeling and some clinical data to really inform.
Great.
But just to add one very quick consideration, we don't have the data on long-acting rilpivirine and rifampicin. So because the model was on cabotegravir, so we don't know how large is the effect, as far as I know. So that's another thing we need to compensate probably.
I think the model, I'm sorry, that I did have another slide on the modeling for rilpivirine, and it was covered in the same. So yeah, sorry, I cut it for time, but that in that same PBPK model from the Liverpool group, they did project both rilpivirine and cabotegravir exposure to be significantly lower.
Terrific. This next question is really for the group. And it's related to giving cabotegravir and rilpivirine every 8 weeks instead of every 4 weeks. Even though the every 8-week administration of cabotegravir and rilpivirine was non-inferior to the every 4-week regimen, there were 4 times as many treatment failures, virologic failures, on the every 8-week regimen as compared to the every 4-week regimen. And the majority of those, I think 6 out of those 8 failures, had new rilpivirine drug resistance mutations. So is every 8-week therapy for everybody, or are there subsets of patients for whom we should prefer every 4-week administration instead of every 8-week administration? And Kim, I can see you thinking about it. I don't know if you have an opinion on that.
I think you're right. I think there's going to be there's so much variability if you look at all of the PK curves. And I think Andrea, as well as you, spoke earlier about the differences that we see in patients with higher BMIs. There's differences based on sex that have been observed in the elimination rate. So I think right now it's hard to predict. I think we have some indicators of who may not be good candidates for every 8 weeks, but I think we need some more data in that area.
Andrea, what do you think? Do you think that everybody can get every 8-week therapy, or do you think we should be looking for people for whom maybe every 4 weeks is better? And you're yeah.
So It's hard to answer. I think at this time the data we have suggests there might be a very slightly higher risk of failing and selecting. So I think we don't know. We probably need more data in real life to accrue select patients. But the risk is so small that probably we can start with every 8 weeks with everybody. But there's this risk, as you mentioned.
And Andy, what about the cost of every 4-week versus every 8-week therapy? Is that going to really factor largely when these drugs are used in low and middle income countries?
Yeah, I mean, it's not just the cost of the drug itself, it's the burden of all the visits. I mean, if people are coming to the clinic every month, that's 3 times more often than they would normally if they were coming for oral treatment. And there are some guidelines now suggesting people could come even every 6 months to get their oral drugs. So, I mean, ideally, you'd have a long-acting treatment getting towards target dosing frequency of once every 6 months. And as it goes to 8 weeks and then every 4 weeks, it becomes harder and harder to implement on a large scale.
And then, Andrea, let me get back to a comment you made. Do you think it would be valuable doing therapeutic drug monitoring of cabotegravir and molpivirine? And would you do it in everyone, or would you only do it in a subset of patients at high risk for having suboptimal drug concentrations? For example, women with a high BMI.
I think it would probably more available in those and quite early, because we saw that the failures and even underdosing was mostly in first week. So probably in those patients and in those frame of time.
And what would you do for a patient who had low drug concentrations? Would you give them a booster dose? Would you switch them to oral therapy? What would you do?
That's another thing we probably don't know at this time point. Maybe switching them back to oral, or just having a very brief period of both intramuscular and oral could be a solution, but we modeling to decide the best way to manage it.
Okay, terrific. Well, we unfortunately need to go to a quick break before our next session begins. I would like to thank Dr. Calcagno, Dr. Scarsi, and Dr. Hill for a terrific session. Thank the audience for their participation, and hope everyone enjoys the rest of the day and is continuing to learn something from this forum. So thank you all for your participation, and now we'll go to the break and then the next session. Thank you.